Now, I'm very fortunate and pleased to be able to introduce our keynote speaker, Dr. Matshidiso Moeti. Dr. Moeti is the WHO Regional Director for Africa, the first woman WHO Regional Director for Africa. We're proud of that. And it's great that she's a woman, but she's doing some quite interesting things, leading health transformation in the African region through an agenda that is building a responsive, effective, and results-driven regional secretariat. And we were speaking earlier about how one handles that and priorities in the complex. We have enough difficulty in one country when you're dealing with a region that has multiple countries and cultures and the diversity that you have to handle. And it was an interesting set of responses. She's focused on advancing towards universal health coverage, accelerating progress toward global development goals, and, of course, tackling emerging threats. Strong partnerships are underpinning every aspect of the regional office's work during her tenure. She is also a public health veteran with more than 35 years of national and international experience on the front line of the transformation that is undergoing in Africa. She joined the WHO Regional Office in 1999 and has held several senior positions in the organization, including Deputy Regional Director, Director of Non-Communicable Diseases, and WHO Representative to Malawi. So she's gone through the system. Under her leadership, the Regional Committee for Africa in 2016 adopted the framework for implementing the Global Technical Strategy for Malaria, 2016 to 2030, in the African region. Will you please join me in welcoming Matshidiso Moeti, Dr. Moeti.
Dr. Rabinovich and the leadership of the American Society for Tropical Medicine and Hygiene, distinguished participants, ladies, gentlemen, and colleagues, it's a great honor for me to have been invited to your 67th annual meeting and to be invited to speak to you about, I was told pretty much whatever occurred to me, it might be interesting to talk to you about. So that's a great deal of freedom. Very often my colleagues give me speeches to read. It's like, go and say this, go and read that. So this was really a privilege to sit back and have the opportunity to think, what do I want to talk to these scientists, researchers, and actors in tropical medicine and global health about? First, it's an opportunity not only for me, but also for WHO in Africa, for all my colleagues in the African region, because we have here, and congratulations for having a meeting that reached this number, we have here scientists and experts who are very interested in working to improve health in the African region. I think many of your members from different disciplines, areas of interest, working in different countries, are collectively working to contribute to improving the lives, health, well-being of African people, which is my responsibility as the leader of WHO in the African region together with my team. So I believe my being here, and we spoke about that earlier, offers opportunities to explore how the work that WHO does could interface with what all of you do in African countries in order to support the countries, the governments, to do what they can to improve health. So I'm very excited that at the same time we have a deputy minister from Guinea-Bissau, we have the ambassador from Mali, because they play a strong role in guiding and contributing to the policies, the programs, ultimately the services that their governments working with all of you and working with the international community are going to put in place to improve the health of the people. So it's a great opportunity. Okay, I need to know where to push here. Okay. Oh, it's here. Okay, we missed to have a briefing and a rehearsal. So I'm not quite sure. Ah, there we are. No, no, need to go back. Right. So I thought that faced with a room full of scientists, I didn't realize there'd be 5,000 of you. There's not much point in my trying to delve into what you know even better than I do. But to try and situate this discussion in what is currently going on in global health in the African region, the work that's ongoing on the Sustainable Development Goals, and the need that's been well recognized by national leaders and the international community for this, all of the work that you do, the research, the knowledge, the science, the new technologies, the new products, to be delivered ultimately through functioning national health systems in the countries. And there, as we like to say, to make sure that these services leave no one behind. So reach everybody. And having been in my youth and continuing to be an activist for women's rights, for equity among women, I thought with such a strong equity focus in the discussion around the Sustainable Development Goals, there is need for us to continue to explore and to make sure that the inequities that bedevil women's lives every day need to be addressed as part of what we all do in global health. And we need to do better than we did in the MDG era to make progress and to succeed. So I've just come from Kazakhstan. I've had a very extraordinary trip. So this the time zone, I think it's about 11 hours ahead of here. So I flew from Astana yesterday, where we were celebrating 40 years of Alma-Ata primary health care and that determination to provide health for all that was made so many years ago. And there were many discussions there about equity, not only working in a systemic way to make sure that all the science, innovation is translated into action and services that reach people, but making sure that nobody is left behind and doing better than we did in the MDG era to address not only issues of equity in the systems, but to look at particular groups, population subgroups, whether they be vulnerable people in relation to one problem or one disease, or other groups that need particular attention to be made in order for them to be among those who have access to services, who are able to express their demand for services effectively to improve their health and well-being. So how does this affect women, and why do I consider that women are so important in relation to this question? First of all, we know that well, in Africa, that is, women constitute just over half of the population. So they're a group that matters in one way or the other. We also do know that women play an extremely important role in providing health care in the public health systems, in the formal health systems, and very much at home, at the community level. Something that ensures, that places them at higher risk of some diseases, as we will see as I carry on with this discussion, but something that holds out huge potential for their contribution, not only to public health, to health development in countries, but to socioeconomic development in their countries as well. This is, I know it's been decades since this has been discussed, but it's my view that this is still very much a work in progress, and we need to remind ourselves and to review how we are progressing with exploiting and leveraging all the potential and capacities that women have to contribute to health, while also insisting on ensuring that as beneficiaries of health systems, they have access and can make their demand in an equitable way to the health systems for prevention and care, treatment, and rehabilitation that they need for their own health, because they're such a powerful contribution to health development and, as I said, to socioeconomic development in Africa. So we also know that although women are so represented in the healthcare systems in countries, they do tend to be under-rewarded, also partly because they tend to occupy, they don't occupy the highest positions of leadership, which is again another loss, because with women's voice being heard in policymaking in countries, I believe strongly that we can have better outcomes in health in the region. I won't say much about the underpaid role of women as caregivers in the home. This is a phenomenon not only in African countries, but also in Western countries, in all countries, in fact. And it's something that is a challenge in societies, but needs to be recognized, and we need more effective strategies to deal with this. When I was doing my master's in public health, which is many years ago now, at the London School of Hygiene and Tropical Medicine, I remember writing an essay as part of the coursework which touched on this. And honestly, I don't believe that we've made all that much progress in adequately, fairly, justly rewarding women for the contribution that they make in health. And of course, we know if we address the socioeconomic determinants of health, we will work on areas like education, empowerment of women, representation of women in decision-making positions. That'll help to contribute, that'll help to unleash the potential economically of all these women to contribute to economic development in countries. I believe some clever economists have quantified what the lost opportunity if we're not making progress in this sense. So what is the situation of women's health in the African region? I won't dwell very long on this, but simply to say that when we talk about women's health in Africa, very often we zero in immediately on their sexual and reproductive role and health, and these are health problems that are of great importance. We know that in the era of the Millennium Development Goals, we did make a lot of progress in improving health in Africa. Child mortality reduced significantly, maternal deaths reduced somewhat, not to the extent that had been anticipated, and this has something to do with the status and very much the quality of health services that are available in African countries. There was a reduction in the mortality from malaria, from HIV, AIDS, and we see here the graph showing how maternal mortality, so maternal deaths per 100,000 live births reduced in African countries. But we also note the difference between what's happening in Africa and what's happening in the rest of the world, including in Southeast Asia. So these rates in the African region are very much higher. And if we look within African countries, within the African region, we see quite significant differences as well between countries like Niger, Chad, and others, perhaps like Namibia and the Seychelles. And this is directly related to determinants of health that are structurally determined, socially determined, which we need to address, including, I believe, in the work that you are doing in tropical health, in communicable diseases, if we're going to make the progress that we need to make to improve the health of women. So here, for example, we know that women's access to family planning services are not where they should be. There continue to be huge gaps, and this is particularly the case for adolescent women who tend to have higher rates of maternal mortality when they do give birth, if they do fall pregnant. And some of what determines this is women's economic status, their income, women's decision-making authority within the home, which is determined by many things, by their level of education, by the resources that they have, and by the social structure in which they are living their lives. We talk a lot, and if you look at the literature and some of the strategies around the Sustainable Development Goals, there is great emphasis on what is called multi-sectoral action, or health in all policies, or addressing the determinants of health. And it will require us to work in very different ways from what we do currently, and just emerging from work that was done on HIV/AIDS, malaria. I recall saying to a good friend who is the leader of UNAIDS that my expectation was that in addition to emphasizing access to treatment, the elimination of prevention of mother-to-child transmission of HIV, I was expecting us to do much more work on prevention, which requires interventions that go way beyond what happens in the health sector, in the health system, and really deals with some fundamentals of equity, power differences, gender relations, gender equity differentials between men and women in order to really enable prevention to take place. And this is very relevant for what is the situation as far as HIV is concerned. So this slide just shows the differences in prevalence, in new infections between men and women in the African region. And for the reasons that I've stated, gender inequities, women's inability to avoid, based on their socioeconomic status, having risky sexual relations with men, we see that very dramatically. If you look at the information about the youngest women who get infected, we have more than twice the number of new infections of HIV among 15 to 24-year-old women than we do among males. This is a direct consequence of the difference in terms of access to preventive services and the authority and power to say no when a young girl does not want to have either forced or coerced sex or sexual relations simply out of economic necessity, which is still a reality for many women today. But women don't only have illness related to their sexual and reproductive lives. And here again, to show that as far as neglected tropical diseases are concerned, at least in the case of trachoma, partly related to their role in society, the work that women do, looking after children, being at home, in environments where we don't have access to safe water, sanitation, hygiene practices, and looking after babies and children. Women are more vulnerable to trachoma infection than are men. And women's vulnerability to genital schistosomiasis also drives their vulnerability to HIV transmission. So these are areas, I believe, that need to be addressed not only with a purely scientific lens, but we need, as we are putting programs in place, to consider the gender-related, the social determinants that drive vulnerability, and work on interventions that address these directly. I believe this is the difference that we're going to have to make as we work on these so-called health in all policies and on the social determinants of health to drive better equity. It's very often forgotten that women are also affected by the newly emerging epidemic of non-communicable or chronic diseases in Africa, as well as in other places as well. And there's data that gives great concern in the trends that we are seeing in not only prevalence and mortality, but also the risk factors that drive the non-communicable diseases, as is shown in this slide. So we have, at any moment in time, about 500,000 women with cervical cancer, out of whom 300,000 plus die every year. And this is more women than die giving birth to children. So if we look at the attention that goes to maternal mortality, we see that we really need to be working on addressing some of the risk factors that drive this. And this, for example, is related to low coverage of cervical screening services at the primary care level in most countries. If we look at the priorities that are articulated in the national health policies and national health strategies in many African countries, somewhere we will find non-communicable diseases. And then if we look at the budgetary allocation, how those priorities translate into resources and programs to address these newly emerging areas, we find that there's a huge amount of work to do in terms of advocacy, policy making that is based on evidence, and providing the services that are needed. And the risk factors are equally important in the emergence of non-communicable diseases, including what some people call the commercial determinants of health. So we've talked a lot in WHO about the social and economic determinants, we know that some of the drivers of these risk factors are directly related to the marketing of tobacco, marketing of alcohol, marketing of unhealthy foods, and of course, as far as women are concerned, very much the lack of opportunities and spaces to live more active lives, to exercise. I remember when I was a young doctor and I went back home from my training, I used to jog with a friend. This was in Botswana, in Gaborone, more than 30 years ago. And honestly, we were jogging on the roadside, and one of the strongest reactions that we used to stimulate was among young men, our age groups, who used to mock us. Well, where are you running? What's going on with you? So the idea of women wearing perhaps not very modest clothing and running along the roadside at that time in Gaborone was not acceptable. This has changed, but I think if you go to many cities and try to find where a low-income woman who can't pay the fees for a gym is going to be able to exercise, you'll find it's very difficult to find safe spaces, safe in terms of road traffic accidents, but also safe in terms of acceptance in the society where women can exercise. It's very, very few places. So again, these are policy decisions that need to be based on evidence, that need to emerge as governments decide, and partners, how to invest their money in African countries. Because we would be trying to avoid to see the emergence of this epidemic of chronic diseases, which is already a reality, simply because the national health systems in the African region are not yet adapted to treating these chronic diseases. So how can we learn from the work that some of you are supporting in dealing with communicable diseases to help countries to adapt their healthcare systems so that people who need chronic care can be able to find affordable, available chronic care services where they are living? It was very notable that not only are women affected disproportionately by diseases related to a sexual and reproductive role, but in fact, even in outbreaks, and I'm just giving the example of Ebola outbreaks, a succession of them through the years, women, because of their caregiving role at the home, are the first to be exposed to Ebola. And we see here that the number of women who died compared to men in the Ebola outbreaks has been more. This we can understand intuitively. At home, it's women who are providing care. In the hospitals and the clinics, it's women who are providing care. And when it comes to those rituals and rites of preparing bodies for burial, it's very much women who are involved and concerned, including younger women. So in the interventions and the risk communication that we are collectively engaged in, we need to be aware of these gender differences. And my observation is that we provide very gender-blind, you are at risk type information to people, and who provides this information is also important for it to be receptive to women and to protect the right people. I did notice in the Ebola outbreak in West Africa that, of course, we were saddened and struck by the loss of many healthcare workers, but it's mainly when doctors died that we heard about it internationally. Many nurses died in that outbreak. Many women of different ages were affected and lost their lives. I didn't see this a very prominent aspect of the communication about that Ebola outbreak, but it is a fact that women play a key role in providing care and can also play a very important role even at the community level in supporting surveillance, in supporting the first alerts that something unusual is happening in terms of a disease pattern, because they are at home and they are the ones who are observing what's going on in disease patterns. I won't go into this in a lot of detail, but not only in humanitarian crises where we have population displacement, conflict, is the provision of routine health services, including reproductive, maternal health services, jeopardized in countries. But in the Ebola outbreak as well, in West Africa, we saw that the fear of being infected, of providing services to women in those in that context of a lack of infection and prevention amenities in clinical services meant that many women were not attended to as they should have done, and we had maternal deaths increasing in ways that were not to be expected. So we have many drivers of women's health or women's ill health in the African region, as we do in the world. Some economic factors, we know that women are poorer in general than men because of many factors, including education, access to jobs, and we also know that even when women and men are doing the same work, not only in African countries, the remuneration can be very different. I've seen dramatic stories of the difference in pay between men and women who work in the BBC in the UK, which surprised me a great deal. In my own history, I happen to be the child of two medical doctors who were working many years ago in the Botswana public health system. And my mother earned less money than my father for doing the same work, and carried out a little campaign in the House and in the Ministry of Health to receive a fair salary for the work she was doing. It took quite a few years for that to be rectified, and I remember my dad being a bit embarrassed, a bit shamefaced, but he wasn't the decision maker at that time. But there was a real injustice in paying my mom was the first African woman to work in the Botswana public health system. I think the authorities simply didn't know where to place her, but it certainly didn't occur to them to place her at the same salary level as her husband, who was a doctor in the same system. So these are some of the factors that drive that area of vulnerability among women. Another issue is to do with the national health financing policies in countries which provide or don't yet really provide health insurance for people, and then women's ability to contribute to their own health insurance so that they don't have to pay out of pocket when they have to use health services, which is a huge cause of people not going to health facilities or families being impoverished, and this is particularly severe as it affects women. Geographic factors, I think everybody is aware that in rural areas, access to health service is very much more limited, and women sometimes have to walk hugely long distances, including for seeking care for their reproductive health problems, and even for going to deliver babies. So geographic factors are important, but not only rural-urban divide. We found that people living in low-income urban areas, in the urban slums, are also at a great disadvantage. We're able to show the Minister of Health of Côte d'Ivoire, for example, that Abidjan has a maternal mortality rate which is way higher than the neighboring countries, Burkina Faso, those poorer countries. And this enabled us to convince her to provide primary care services within the city that would enable women to be safely delivered by a midwife instead of having to queue at the university hospital, where the overcrowding caused the quality of care to be so bad that the number of maternal deaths there was hugely increased. Other factors are to do with the inadequacy of healthcare services more generally, in terms of quality, from the gaps in infrastructure, in human resources, in procurement and supply of medicines. One of the most common problems suffered by people in African countries is the lack of stockhouse in medicines, including medicines for some of the diseases with which you as a community are very much concerned. Malaria medicines run out in very many countries. So the health systems in countries need to be better organized, better resourced in such a way that they deliver for the priority diseases that afflict populations, including women. And then the gender-related inequities, I won't go into detail because I've already mentioned, including some cultural factors that lead to women not being educated, not having their education invested in as it should be, including young girls being married off early, female genital mutilation, and a whole lot of other cultural factors, including women's ability to decide that they are ill, they are going to go to the clinic and the hospital, they're going to take their children for care. Universal health coverage is something that is very topical at the moment. As I said, I just came away from a conference where the strategies to address this were being discussed in a lot of detail. Our Director General, Dr. Tedros, was instructed, really, politely, by 3 heads of state to develop an action plan for the 3rd Sustainable Development Goal, working together with other partners. And this action plan was just launched in the World Health Summit in Berlin the week before last, and then also in Astana last week. And the idea here is for people to have access to the essential services that they need. And we observe that this is a challenge as far as women are concerned because of the factors that have already been mentioned, being empowered, being able to take decisions to go and access healthcare. Secondly, that the financing needs to be developed in such a way that there are first of all, there is additional domestic investment in health in countries broadly, which will deliver for women's health as well as for health more broadly for the population without people undergoing financial difficulties in paying directly without any insurance schemes being put in place. And I'm very encouraged to see that some countries and some policymakers are taking action to develop these prepayment pooling health insurance schemes starting at the community level in countries like Rwanda, which has managed to pretty well eliminate inequities between households at different income levels in accessing a basic package of healthcare services to others that are being carried out at the more central level, places like Ghana, Gabon, where attempts are being made to provide prepayment and subsidize the needs of lower income households so that people don't have to pay directly out of pocket to access basic healthcare services. There's some very interesting examples in Nigeria of private sector investors working with low income households and non-governmental organizations to help low-income people to contribute to their own health insurance schemes in ways that enable them to have better access to basic health care, more than would be provided in the public system in government health facilities. One of the drivers of the changes that we need to see for women is women themselves being able to be involved in decision-making, being in leadership positions. So not to flatter myself, but I'm showing you this picture of the First Lady of Rwanda. We organized a couple of years ago an African Health Summit in Kigali, and here we had a session with the First Lady of Rwanda and the Minister of Health of Rwanda. That's the lady in the orange dress, and I have the privilege to be sandwiched between these two people as we were talking about the health of adolescents and particularly of adolescent women. Because what we observe is that women's empowerment needs to be translated through education, through women being given the space to make decisions in the home, and women being in decision-making positions, in policy-making positions in the public as well as the private sector. We see here a slide looking at the Gender Development Index and showing the Gender Development Index, which is based on education status, access to resources, and decision-making space and authority for women, and how our region still lags behind in comparison with the global average and other regions. And this index simply shows what is the reality of women being able to make decisions and influence the outcome in terms of health for themselves particularly and for their families. We note that there are still gaps to go, but as I'll show you in a minute, we are very encouraged by some of the progress that's starting to show up. So just to take an example, if women are empowered in terms of differences in education, in terms of income, and in terms of their position in marital relationships, we see how women are better able to have access to a skilled birth attendant in order to have a safe delivery. So it matters. It matters a great deal, and it's something that compels us to want to pay better attention to, for example, education as part of our striving to improve women's health. So it's not something that has not to do with the direct action of the health sector, but which deserves our advocacy in order for governments to invest more in the education of women for us to see better health outcomes. We are starting to see improvements in women in leadership in the region, as I said, in the political space. And it matters a lot whether we have women parliamentarians and women ministers, because they do influence the policies of governments, whether we have women leaders in the private sector, in private companies, who are able to make certain decisions. And what is the situation of women leadership in global health? So I was very excited to be approached by a movement that's going on in improving women's representation in global health, particularly in decision-making positions in global health. And we as WHO are partnering with this group to see how to mobilize women's involvement in the African region in global health, and networking, identifying women where they are scattered in countries, in institutions, including African women working in organizations abroad, to work together as a group and to advocate for the improvement of women's status as it relates to health, to their own health, and to their contribution to global health. I think that this is a movement that's going to have a huge impact. We are working with them now to mobilize and identify women in Francophone countries who are involved in global health. And the connecting of women at key events, in my view, is going to be a powerful incentive for us to work together and influence in different spheres the decisions that get made, so that we address the inequities and are able to unleash women's potential for health. So in the context of universal health coverage, working on the Sustainable Development Goals, what is it that we need to be paying attention to in some of the strong directions in which this work is going? First, I won't say it again, we need to improve the rewards, the recognition of women's contribution to providing care in health, and also to improve their leadership positioning in this, not only as caregivers at home or in primary care clinics, but as leaders in public health, leaders in clinical health, and leaders in some of the organizations that influence policies in global health. In addition to that, we need to pay attention to rewarding and do the advocacy and find the strategies that enable women to be rewarded for the work that they do providing care in families, and the opportunities that they miss to be involved in other outside activities, including in earning an income. This is a problem, as I said, globally, not only in African countries. We also are very excited at some of the opportunities offered by research and development, the work that many of you are doing here, and innovation in contributing to global health. And I would like to urge that we make space for women to play their role here as well, women to be engaged in and contribute to research. I'm very excited when I go to some of these conferences and find young women researchers having opportunities provided for them, being funded to, first of all, be trained, grow their skills. There's a program called the EDCTP, the European Development Countries Partnership on Research and Development, which has a very strong emphasis on supporting and training women researchers and unleashing that potential that they bring. For example, in innovation, which is something that many of you in the society are involved in, we are also keen for women to be given the space and the opportunities to play their part. We see that technology is playing a very strong role now in contributing to universal health coverage, to progress in health. And I'm hoping that, again, here, women will be provided with the opportunities to make their contribution and take part as not only recipients of the benefit of technology, but innovators, people who provide brilliant ideas on how to innovate and improve access to healthcare. I believe that all of this, paying the real attention that, 40 years of discussion on gender equity have simply not been able to deliver. I believe that in the work that we are going to be doing on the social determinants, while we look at different income quintiles in a gender-blind way, we could benefit a lot by focusing particularly on women. They're a huge force for change. They are engaged in providing healthcare already, in leading, in ideas, and investment in a particular way and targeting, I believe, will make us reach universal health coverage all that bit faster than we are progressing at the moment. Thank you. And for that, I look forward very much to encountering, working through the leadership of the society, how we as WHO, in the reforms that we've tried to put in place, can interface with you in the influence that we have on decisions in countries, on policy, strategy, service delivery, how to harness the good work that you are doing and make sure that they translate into services for people. Because if that doesn't happen, it's going to be very difficult for them to make a difference in people's health. Thank you very much.
Thank you. Thank you, Dr. Moeti. That was insightful and inspirational kickoff to the meeting and challenging some of our assumptions and the way that things have worked in the past. So we have something for you. Hope that it will remind you of the words that you spoke to us today, but also the opportunities we had to listen to you. And so thank you very much. Thank you very much. Okay.